Welcome. Good afternoon. My name is Dee Fenner, and I'm the chair of the Department of Obstetrics and Gynecology and the base professor of Diseases of Women and Children. And I'm going to moderate today's panel. I'm delighted to have you join us. Today, we're here to discuss women's health. Being a woman impacts many things beyond gynecologic care. It increases your risk for certain diseases. It changes the way that conditions may present, as you'll hear about cardiac disease today. It can affect your energy, your mood, and even your immune system with hormonal fluctuations. So we've brought together a panel of University of Michigan health experts to share their insights and the latest research on various aspects of women's health. Thank you to everyone who sent in questions in advance for our experts to address. We'll also take some live questions after the panelists do their presentations. If you're watching live on Zoom, you can submit questions in the Q&A button at the bottom of the Zoom screen. And if you're here with us today, we'll send around some microphones after the presentations. Our panelists are leaders in their fields and dedicated to making a difference. And it's my pleasure to introduce them to you. Today, joining us is first Cherise Loader. Dr. Loader is an associate professor in the Department of Obstetrics and Gynecology, and she's the director of the Clinical Family Planning Services. We have Dr. Melinda Davis. She's an associate professor of internal medicine, as well as an associate professor in the Department of Obstetrics and Gynecology. And she also serves as the program director for the Fellowship in Cardiovascular Disease. Next is Dr. Natalie Saunders. She's associate professor in obstetrics and gynecology and the assistant medical director at the East Ann Arbor Health Center here in Ann Arbor. And finally, we have Dr. Versha Pleasant. And she's a clinical assistant professor in obstetrics and gynecology, and she's the director of the Breast Health and Cancer Genetics Clinic here at the University of Michigan. At this time, I'd like to give each of our panelists the opportunity to talk about some specific areas of their expertise. Following the presentations, we'll begin with the Q&A session. So, to begin, I'm going to hand things over to Dr. Cherise Loader to get us started. Dr. Loader.
Thank you, Dr. Fenner, for the challenge of speaking about reproductive rights in 5 minutes or less today. Today I'm going to talk about the context of clinical care in terms of reproductive rights in Michigan. And as Dr. Fenner said, I am an expert in complex family planning, which means I've done additional training to care for people who are terminating their pregnancies. And I also care for patients experiencing pregnancy loss and also patients who want birth control or contraception. And what does that look like in terms of care in Michigan? Well, most of my patients who are referred to Michigan Medicine are referred because they need a higher level of hospital care. While many patients can receive care in the outpatient setting, some have serious medical conditions and need hospital level care. Most of those patients have had something unexpected come up during their pregnancy. Sometimes that's a serious health condition that comes up in their pregnancy, like learning from their cardiologist that they're in heart failure. Sometimes they receive a serious fetal diagnosis, and through reflection and discussion with their family, they decide to terminate their pregnancy. We're also referred patients who are diagnosed with a second trimester pregnancy loss and need surgical care at Michigan. And finally, we're experts in ectopic pregnancy care, which is when a pregnancy grows outside of the uterus. But we can only offer this care because abortion care is legal in the state of Michigan currently. But there were certainly some threats to those rights in the last few years. In June of 2022, the Dobbs decision made it so that states were left to regulate abortion care. At that time, we still had a 1931 law on the books in Michigan, which actually banned abortion care. Through a preliminary and permanent injunction, that law was stayed, meaning it was not in effect. But through a ballot initiative, Prop 3, Finally, the right to abortion care, as well as other pregnancy and fertility care, was enshrined in the state constitution. The Reproductive Health Act was passed and removed many unnecessary regulations of clinics and providers, but we still do have some regulations on the books in our state. I'm going to talk a little bit about them in the next slide. I had the pleasure to serve as an advocate and expert witness in a court of claims case called Northland Family Planning versus Dana Nessel. This case challenged a 24-hour waiting period that my patients had to experience, and the requirement that they review biased mandatory counseling materials before they could get their care. It also challenged that only physicians could provide abortion care and the need for coercion screening. As an expert witness, I was able to share the 10 years of experience I have in providing this care in Michigan, that patients don't need to review these materials, or that there's no certain time period that they need to review these materials in, that they usually have conversations with their family and their doctors to make these decisions, and they're sure of that decision when they make it and come for care in our clinics and in our hospital. Fortunately, 2 days ago, Judge Seema Patel delivered her opinion, which removed these requirements for the 24-hour waiting period, mandatory counseling materials, and also the requirement that only physicians provide abortion care. So that expands our ability to provide care in our state. We'll continue to do abortion screening, as this was felt to be an important part of this care currently. My group also advocates in terms of education at University of Michigan, and we teach a lot of learners. We teach medical students, residents, fellows about family planning and about justice and rights. I had the good fortune to have support from the department to develop a novel virtual course where my students enroll virtually and learn from reproductive justice advocates about the threats to rights, justice, and health in our state and in our country. And this is a screenshot from some of my students who attended the class in January. The Complex Family Planning faculty group also does a lot of research around family planning and understanding how policies affect our patients. So some questions that we're asking are, how do restrictions impact patients in their experience of intimate partner violence? How do abortion restrictions impact students who are graduating from midwifery, PA, and nurse practitioner programs? Does that influence their decision about where to get a job? Also, how do fetal personhood regulations impact fertility care? We're also asking important questions about healthcare delivery, like what happens when a clinic closes in Muskegon? Where do patients go for care, and how does that impact their families and their decisions? We're asking questions about telemedicine, like how does telehealth abortion impact our patients in Michigan? And we also want to improve both the patient experience around birth control and how we train our providers. So can we reduce pain by training providers to give a block before placing an IUD, which can be a painful office procedure? Hopefully I've shown you what clinical care we're providing at Michigan Medicine in terms of pregnancy loss and pregnancy termination, that me and my other faculty members are working as advocates, but we're also educators and researchers to further this care. Thank you, and I'll hand this off to Dr. Davis.
Well, thank you very much. I'm glad to be here. Appreciate the invitation. I'll be talking about women's heart disease. And also in 5 minutes, hard to cover the breadth that I would normally like to, but today we'll cover 4 main topics. Heart disease in women, I'll tell you a little bit about some statistics, some of the factors that are unique to women, that are differentiating factors. Unfortunately, a lot of women don't get treated in a timely way, and there are some disparities in that area. And then finally, a note on call to action, what you can do and what we are doing here at Michigan. Cardiovascular disease in women is actually the #1 killer. 1 in 5 women who die are because of heart disease. And this is actually more than all cancers combined. Almost half of US women are living with some form of heart disease, but less than half of women actually know that heart disease is their #1 killer. In terms of pregnancy and heart disease, which is an area close to my specialty, it is actually the #1 cause of maternal-related deaths, is cardiovascular disease. And of pregnancy-related deaths, 1 in 3 are related to heart disease. Unfortunately, this has been increasing and on the rise and has actually doubled over recent years. We've also looked at this data and found that many of these deaths are, in fact, preventable. So how do women differ from men? Both men and women can present with chest pain if they are having a heart attack, but women are more likely to have nausea, fatigue, shortness of breath, or back pain. Unfortunately, women are often misdiagnosed with stress or anxiety. There are anatomic differences. There are smaller blood vessels in women, and sometimes they receive less aggressive therapy. They actually have twice the mortality rate compared to men. On the left side of the screen, you can see some of the classic cardiovascular risk factors we think about for smoking, high cholesterol, high blood pressure. And on the right side of the screen, you see some of the newer risk factors for heart disease that we are identifying. The first 3 are actually things that we see during pregnancy: preterm delivery, hypertensive disorders, and gestational diabetes. But also common in women are autoimmune disease, breast cancer treatment, and depression. From a pregnancy standpoint, I already told you heart disease is the #1 killer and cause of death. And a lot of these deaths are related to high blood pressure, heart failure, stroke, or blood clots. Pregnancy also gives us a window into patients' risks for cardiovascular disease down the road, and those are preeclampsia and high blood pressure, gestational diabetes, and preterm birth. So in our cardio-obstetrics practice, we try to identify people who are at risk and try to help lower those short-term and long-term risks. So why do women do worse than men after heart attack? Typically because of misdiagnosis, delays in diagnosis. A lot of our studies are limited. There are many more men enrolled in clinical trials than women. Women have different anatomy, smaller blood vessels, and they also have more associated risk factors such as diabetes, blood pressure, and autoimmune conditions. So what can you do? You can know your numbers. You can know what your risk factors are. If you are a smoker, if you don't get enough exercise, diabetes, high cholesterol, high blood pressure, those are things to know about. And when we talk about knowing your numbers, you know what your blood pressure is, your A1C, and your lipids. From a Michigan medicine standpoint, we are working to improve women's heart disease knowledge and patient care through advocacy, research, and education. There are many overlapping areas between heart disease and other subspecialties, and there's a lot of work for us to do. So thank you for your time, and I will pass this over to Dr. Saunders.
Can I get the notes view? Thank you so much for having me. I'm excited to talk about a topic that is close to my heart and often not understood very well. And if you're following any social media, you'll notice that menopause is having a moment. So menopause costs American women an estimated $1.8 billion in lost working time per year, according to a Mayo Clinic study published recently. This study examined how hot flashes, night sweats, mood swings, and the myriad of other symptoms associated with this time of life affect women in the workplace. It's the largest study that's ever been done in the United States. Discussing menopausal symptoms and management options with our patients is essential to promoting a woman's health and well-being. So what is menopause? Menopause is the sensation of menstruation, which typically occurs around the ages of 45 to 55, when no uterine bleeding has occurred for the last 12 months. During the menopause transition, 50 to 82% of American females experience vasomotor symptoms or hot flashes. It is estimated that 10 to 40% of menopausal females experience vulvovaginal symptoms like vaginal dryness. The time leading up to menopause is called perimenopause, and that can occur up to a decade prior to menopause. So what's the best treatments? Systemic therapies come in a lot of different forms: patches, pills, vaginal rings, and gels. If the patient has a uterus, a progestogen is indicated to protect the uterine lining or the endometrium. While bioidentical hormones are popular, there is not evidence to suggest that they are superior to other standard products. For genitourinary syndrome of menopause, or GSM, local estrogen is best. Women with both symptoms of systemic symptoms and vaginal symptoms may require a combination of therapies. This is the consensus statement from NAMS, which is the North American Menopausal Society. This is now called just the Menopause Society. To summarize, hormone therapy is most effective for treatment of vasomotor symptoms and genitourinary syndrome of menopause, and has been shown to prevent bone loss and fracture. Risks of hormone therapy differ for women depending on the type, duration of use, dose, route of administration, timing of initiation, and whether a progestogen is needed. Treatment should be individualized using the best available evidence to maximize benefits and minimize risks with periodic reevaluation. For women aged younger than 60 years or within 10 years of menopause onset and without contraindications, the benefit-risk ratio appears favorable. Based on the Women's Health Initiative randomized controlled trials, longer duration may be more favorable for estrogen therapy than progesterone estrogen therapy. For women who initiate hormone therapy later in life, 10 to 20 years from menopause or over age 60, the benefit-risk ratio appears less favorable than for younger women. This is because older women have a higher risk of things like cardiovascular disease, stroke, blood clots, and dementia. So who is not a candidate? It is important for us to identify those who systemic therapy is not appropriate. This includes women with unexplained vaginal bleeding, history of hormone-sensitive cancers like breast cancer, blood clots, liver disease, or significant heart disease. Sometimes your practitioner may use a scoring system to help assess your risks, which is what Dr. Davis was talking about. There's a calculator called the atherosclerotic cardiovascular disease, so putting in some of the numbers that she was referring to. What are the risks of medical hormone therapy, menopausal hormone therapy? In the United States, the incidence of breast cancer is approximately 1 in 8 women. Use of combined estrogen progesterone hormone therapy is associated with a slight increased risk, less than 1 additional case per 1,000 women. This level of risk is comparable to other modifiable risk factors, such as consuming 2 glasses of wine daily, obesity, low levels of physical activity. Notably, estrogen alone therapy may slightly reduce the risk of breast cancer. This is not an exhaustive list of additional resources, but some different forms. The Menopause Society that I talked about, menopause.org is the website. It has lots of great information. A podcast called Overreactive is done by 2 physicians, and they talk a lot about perimenopause and menopause and go into all the evidence. It's excellent. And there's a book called Menopause Manifesto by Dr. Jennifer Gunter. These are all reliable evidence-based resources for both patients and clinicians. Next, I'd like to introduce Dr. Versha Pleasant.
Good afternoon, everyone. It's a pleasure and an honor to be here today. My name is Versha Pleasant. I'm director of the Cancer Genetics and Breast Health Clinic, which is one of the few in the country that provides specialized care to people with gene mutations, family history of breast and/or ovarian cancer, and specialized care to breast cancer survivors. I'll be speaking with you today about breast cancer and genetic testing. I first want to paint the picture of the prevalence and severity of breast cancer in the United States. It is the most commonly diagnosed cancer among women in the US with a prevalence of 13%. 1 in 8 women will be diagnosed with breast cancer in their lifetimes. 1 in 8. Think about friends, family members, right? Some people may have personally been affected by breast cancer. Every 2 minutes, there is a new breast cancer diagnosis in this country. So think about how many more diagnoses there will be by the end of our meeting today. I also want to speak about a special community and how breast cancer can disproportionately impact other people. And so breast cancer generally carries a good prognosis. It's usually caught at stage 1 and has a 91% 5-year survival. However, this is very different for Black women who have an almost 40% increased risk of dying from breast cancer. They tend to have higher rates of triple negative breast cancer, which is a more aggressive subtype, which is harder to treat. They are more likely to have early onset breast cancer, meaning a diagnosis at or younger than the age of 50, and they experience more delays in their treatment. So how do we address breast cancer in this country? Well, unlike many other cancers, we actually have great screening tools for breast cancer. And the main tool being screening mammography. Screening mammograms work and they save lives. It is really important that women get their mammograms every year starting at the age of 40 for average risk people, every single year, despite what conflicting guidelines may say. It is something that is, depending on the geographic location, is usually available. It is covered by insurance, and it is a really, really great screening tool. So I strongly encourage that. Also important to do self-breast awareness at home. I tell patients, you know your breast tissue better than any doctor does. Really important to be aware what's normal for you and noticing if something is different one day, a lump, a bump, nipple discharge, or skin changes. I also want to underscore the importance of healthy living, right? A healthy diet, maintaining a healthy weight for your height is good for any cancer risk reduction. And we have a lot of good data now showing the link between elevated breast cancer risk and increasing alcohol intake. So really important to watch alcohol intake. It's very important that I mention dense breast tissue because this is also having a moment in women's healthcare. And 50% of women have dense breasts, and dense breasts are diagnosed by a radiologist when a person gets a mammogram. And as you can see, there's 4 different categories: fatty, scattered fibroglandular, heterogeneously dense, and extremely dense. Having dense breast tissue is a risk factor for breast cancer. Which is in part due to some biological components of dense breast tissue that we don't quite understand, but also because dense breast tissue shows up as bright white on a mammogram, and so does potentially a tumor or calcification, so it just makes it harder to see. There is now an FDA regulation saying that doctors have to tell patients that they have dense breasts, but there's no clinical consensus on what we should do for patients with dense breasts. And medical societies very differing opinions on whether patients should get supplemental screening with mammograms, MRIs. It's really important you talk to your doctor about this, and it's important that you check with your health insurance company to see what is covered for you. Also important in knowing breast cancer risk is this component of genetic testing. And I tell people it's really important to know your family history. That is a window into your own personal risk. So it's really hard to estimate one's breast cancer risk without talking about family cancer history. Really important for you to sit down with your doctor, review your family cancer history to see if you meet criteria for genetic testing. If you do, it's very, very straightforward. It's covered by most insurance companies if you meet criteria, usually consists of a saliva test, and there are laws that protect people against genetic discrimination if you were to have a gene mutation. I just thought I would include this because we now know that there are many other genes than just BRCA or BRCA, the one that Angelina Jolie has. There are many other genes that elevate the risk of breast cancer that we are now including in genetic testing. I am doing a study called Genetic Risk Assessment with Mobile Mammography. When the University of Michigan launched their mobile mammogram unit several years ago, I said, well, why aren't we also offering people a risk assessment to see if they should see a genetic counselor? And they said, that's a great idea, you should do it. And so that's how that program was started. I am trying to find creative ways to integrate precision medicine into primary care, into the things that we already do. And so when a woman comes for their screening mammogram, we offer them a risk assessment. We sit down with them, go through their family cancer history, enter it into a software tool that links to the national criteria for genetic testing, and it'll tell us immediately if they meet criteria for testing, and if they do, we provide them with a referral. My hope is that I can scale up this program nationwide so that every single woman gets offered this service when they go for a screening mammogram. We've already screened over 100 people. Half of them have met criteria to see a genetic counselor. Half. Right? And they have never been approached by their primary care physicians previously about their cancer risk. So I'm really excited about the potential that this project has to offer. So just some final takeaways. Breast cancer is common and it affects everyone. Really educate yourself about what your risk factors may be. Continue to practice self-breast awareness. Get your screening mammogram every single year, starting at age 40, every single year. And to determine if you may be eligible for earlier screening or more enhanced screening, sit down with a provider and talk about your family cancer history and see if you should meet with a genetic counselor. Thank you so much for your time and attention. I'm going to pass it over to Dr. Fenner for the Q&A.
Well, thank you all. That was a great presentation and introduction. So now we're going to go to some questions and that were sent in. And if you want to pull those up for us. All right. So the first question, I'm going to go to Versha, Dr. Pleasant. So you talked a lot about the genetic testing, and so could you go into that a little bit more in terms of like what family history? People say, well, my uncle had lung cancer or my cousin has this cancer. Could you help talk about who should, what is the important history and who they should give it to?
Absolutely. And I also want to preface this by saying, I believe that knowledge is power. And when we sit down with our families and talk about family cancer history, we're sharing information, we're empowering our loved ones, right? And we could save a life by sitting down and talking about family cancer history. There's so many families where there's this culture of silence and people don't want to talk about cancer or talking about cancer is bad. No, it's really good. Share that information with loved ones. So there are genetic testing criteria set forth by the National Comprehensive Cancer Network. And it is a very extensive table, but included in that are things like having numerous family members with breast cancer, especially on one particular side of the family. Ovarian cancer is a risk factor. Have a personal history of ovarian cancer or having a first or second degree relative with ovarian cancer. Pancreatic cancer is also one of those. Prostate cancer, having a relative that has died from metastatic prostate cancer or has had metastatic prostate cancer. So those are male breast cancer. Yes, men can get breast cancer too, so that is also a red flag. A family history or personal history of triple negative breast cancer, or a family history or personal history of Ashkenazi Jewish ancestry. There are other criteria, but those are some of the major ones, sort of red flags that we need to look for when we're taking down a family cancer history. It's not just about breast cancer because some of these genes like to travel with other cancer susceptibility, so it's really important to ask about all cancers.
Thank you. Dr. Saunders, for many folks who are, get hormone replacement therapy, how effective is it in terms of, say, hot flashes? And is it only when you've gone through menopause, or there's a lot of perimenopausal women who have questions as well?
Thank you. Yes, it is very effective in treating vasomotor symptoms, and that's what it is officially approved for. People will also say they feel benefits of other things like brain fog and joint pain and common other symptoms. So it is a very effective form. It does not need to be started only in menopause. Perimenopause, the period before menopause, is up to about a decade before. And since menopause occurs in most commonly between the ages of 45 and 55, symptoms can occur up to a decade before. So I often see women that will come in their late 30s and feel like they have hot flashes and many of the symptoms, and they've been told, you're too young, you can't have any of the symptoms, and we know that's not true. So it's important to listen and consider hormone therapy in these patients as well.
Thank you. So, Dr. Davis, this describes my mother. It talks about AFib. It's very common in women, sometimes goes misdiagnosed, Can you talk about what are some of the signs that we should be aware of, and when you contact the doctor and the treatment, maybe even?
Certainly. Atrial fibrillation is indeed very common, and it is more common as we get older and can often present in women. And people can have different types of symptoms with that. Sometimes people will feel fatigue, sometimes people feel shortness of breath, and sometimes it can just come and go. People can describe having good days and bad days, and maybe not even realize that they're going in and out of atrial fibrillation. The way to check it is you can check your pulse. A lot of people are having monitors or watches, and it's the irregular heartbeat, which is often atrial fibrillation, not necessarily, and that should really be diagnosed by a primary care doctor or a cardiologist. There are many different ways of treating it. We can slow down the heart rate. We can actually give an electrical shock to get someone out of atrial fibrillation. Many people feel much better not being in atrial fibrillation. And then we have to think about a stroke risk with atrial fibrillation. So some people will benefit from being on a blood thinner. That's the short version.
Yeah, thank you. Dr. Loader, a lot of women have difficulty with contraception, get headaches or irregular bleeding or and quit contraception, may get pregnant when they don't want to, how do you counsel those patients? Where can they get advice? What would your recommendations be?
Thank you. There is a lot of misinformation about both contraception and options for one's pregnancy if they decide to end a pregnancy. I rely on our national organization, ACOG, which has a lot of very helpful patient-facing materials like about birth control, about options for pregnancy, about what an abortion is and its safety, and I direct patients there. We also have a number of resources on our patient education website that we direct our patients to, but it's important to avoid some resources that have misinformation. While many patients are getting information from social media and watching videos about birth control on TikTok, it's always important to talk to your healthcare provider and really talk about the options because some things are safer for people with certain medical conditions.
Thank you. So now we're going to turn to our audience. First here who are live here in the room. If anyone has a question, we have a microphone. Don't be shy. Would you like to raise your hand and ask a question of the panel? Great.
Thank you. One real quick, the ACOG, was that, how do you spell that?
Yeah, it's the American College of Obstetricians and Gynecologists, acog.org. And I also point patients to bedsider.org, which it's a website that was developed to teach teens and young adults about contraception, and that has a lot of very friendly videos, tutorials to watch about birth control options, and so that's what I recommend for young people.
Great. So that's bedsider.org.
That's correct. Yeah.
Okay, wonderful. My other question was for menopause. I was curious I went to a OB/PA who gave me lots and lots of information. I was a bit overwhelmed with all the information. Being 54, I had lots of symptoms, not menopause, not through it yet, but getting there. And she gave me all the prescriptions for the hormones, the stickers, and then progesterone, all of that. And then it's so funny, then everything stopped. No hot flashes, right? I always feel like Murphy's Law, right? Everything, all the symptoms stopped. And so when I asked my doctor, should I still do this? And she said, well, if you're not having symptoms, don't worry about it. Don't do it. But I remember the PA really was very adamant about the hormones are wonderful. That helps with heart disease. It helps with decreased dementia. It helps with all these different things. And she sent me a lot of materials to review it. But I have to tell you, when I read the materials, I don't feel like they said that in the materials, that it was really good for, to reduce heart disease, to reduce risk for heart disease or dementia or things like that. And she also, and in the materials that I read, it said, for the shortest period possible for the smallest amount. And I felt like she was saying it was more longer term. So I guess I'm curious about like duration. How long do you do this? Is this years? Is your rest of your life? Like how long do you take this? And then the benefits, does it really help reduce risk for like heart disease or dementia or things like that? Or is it just a symptom of brain fog, but not help reduce the risk of dementia?
That's a great question. Thank you for sharing your personal experience. It's sort of a complicated answer. We know that it decreases symptoms, and we know that it helps prevent bone loss and fracture. The other things are sort of emerging. Like some things suggest that if you take it in your 50s and you have a benefit of lifelong longevity, there is more risk as we get older because of our risks of cardiovascular disease and strokes and things. So it's safer to be on it in your 50s than in your 80s. There's not great evidence. There may be evidence of cardiovascular disease. It's sort of emerging, but not, I wouldn't say that, yes, this is definitely true yet. There seems to be a little bit of a decreased risk in women receiving a diagnosis of type 2 diabetes and that take menopausal hormonal therapy. So some of this is we just don't know yet. And dementia is in the same bucket as cardiovascular disease. So I do not recommend to people to take it because they have a family history of dementia. We just don't have enough evidence to suggest that. So I think it is beneficial. It's something that I assess, and most evidence suggests taking it about a decade is sort of the right answer. But if you're unfortunately diagnosed with breast cancer, then that changes your risk factor, and that's a different discussion. Or if you're unfortunately one of the people that has a stroke or something like that. So it's nuanced, as everything. There's definitely benefits that we know. Decreased risk of colon cancer is another benefit that's known, but there's also unfortunately risks. So it's a kind of a long discussion about like, and then it's also do the benefits outweigh the risks for you? So there are women that when they're later in life, they try to come off of it and they decide I do not feel well, like I do not want to be off of it. And then it's a discussion of like, I think that this could potentially cause harm, but your well-being is very important. And so it's a discussion of how, like, where do you feel, and some people feel very strongly they're going to stay on their hormones. And that's appropriate because, you have agency in deciding of, what your risk you're willing to tolerate or not. Does that answer? Okay, you're welcome.
Melinda, you want to comment from the cardiovascular perspective?
Yeah, I think it's such an interesting area that I'm excited to see more research come out of this. It's not in mainstream cardiology, like in our guidelines for prevention, we are not going out of our way to recommend hormone therapy. There were some studies in the past that showed a lot of increased risk with heart disease, and so I think the pendulum swung the opposite way. I think we're now coming back into like a middle area where we can really think about what are like someone's specific risks and could it actually be helpful in some people at some point in time.
There's a question.
Hi, I have a question regarding dense breasts. You had highlighted that it's a little bit more difficult to detect a breast cancer in dense breasts. Do you see any emerging diagnostic technologies or anything like that specific for that category, or any, other therapies or anything on the horizon?
Thank you for that question. There's breast imaging that is showing a lot of promise that may be better suited for dense breast tissue. The FDA has approved a 3D ultrasound for dense breast tissue, although the studies are not quite there yet, showing that they're superior to mammogram or breast MRI. There's also the issue of availability of such a device. The one that I know of in this region, I think there is one in Detroit, but not one at other facilities. So availability is a big issue. But what we do know is that breast MRI is a lot more sensitive than mammogram and can see a lot more than mammogram. And so often that may be a next step for patients that have dense breasts. It's worth exploring if someone is eligible for MRI with dense breast tissue. But the caveat here is I have seen patients whose sole risk factor was dense breast tissue, and their providers ordered them an MRI in addition to mammogram, and insurance would not cover it for that reason. So that's why I really stress to patients that you must call your insurance company to see what is covered. There may be some variety there, but you know, as someone who orders a lot of breast MRIs, and I see the power of breast MRIs, I encourage patients to explore their risk overall, right? Dense breast tissue may be one risk factor, but there may be other risk factors for which, you know, I see patients that do meet criteria to get a breast MRI once a year, and it's because they have a strong family history of breast cancer, or they have a gene mutation. There may be other things, other reasons for why someone could get that screening. So again, worth exploring the entirety of one's risk and worth calling your insurance company to see what is covered.
Yeah, we have time for one more from the audience.
My question's a little bit more during perimenopause. I think the on-again, off-again symptoms make you wonder whether there's something you should be doing or not doing. If you wanted to be cautious and wait for hormone therapy for a while, are there other things that you can do to help, you know, calm and regulate the body besides just having good diet and good habits? Like maybe additional supplements or things you might recommend?
Yeah, there's not anything that we know for sure is helpful in terms of supplementation. The symptoms, a lot of people complain about anxiety during perimenopause, and part of this is that your ovaries are not making eggs every month, and so your brain puts out all this hormone to try to make your ovaries make eggs, and so that increases anxiety, and people have a lot of symptoms with that. So it's potentially helpful to treat like some of those symptoms. In somebody that's hesitant, there's nothing wrong with not using hormones. That's absolutely appropriate. I do think a lot of times, eventually people find that they feel like any risks that they may incur, the benefits outweigh them. And then a lot of times, I mean, my follow-up with people is often, I feel so much better. I wish I would have done this sooner. So it's really a personalized coming up with the thing that you feel the most comfortable with and that's safest in terms of dealing with some of the symptoms.
So from our virtual audience, the first is like, why are so few doctors trained in menopausal issues, and what's the medical community doing about this? And there are very few doctors in this person's area that have the Menopause Society designation. So maybe I'll maybe address that a little bit. How's that? As the chair of the department and a national leader in women's health, focused a lot around education and training the next generation. I do think that there's many reasons for this. Much of our training, whether that's in primary care, internal medicine, family medicine, and including OBGYN, that the amount of information is doubling at such a rate that sometimes it is hard to focus on certain areas. We may tend to focus on things that, I will say, may have the most danger for a particular patient, or high-risk conditions in pregnancy, or other things, rather than on menopause, because we don't think that women don't die from menopause. I always say menopause, urinary incontinence, these conditions, women might not die, but it takes their life away because they can't function and have happy, functional lives. So shame on us. It is up to us. Thankful we have Dr. Saunders and others in our department who can help train our residents and do more to educate our primary care providers in hormone replacement and other treatments for menopause. So thank you for calling us out. because we do need to make sure that we care as much about the quality and happiness for women moving forward. So I'm going to keep that one in the back of my head and keep pushing for it. The next question is, for those who don't have family history of cancers, does the change in recommendations for screening other preventive care, maybe you want to just talk about the annual mammograms and the age cutoff and why some of these newer recommendations have come about in the last few years?
Absolutely. So family history is one of the critical windows into one's personal risk. But if I had more time, I could tell you about some other risk factors. There are some personal risk factors that people can have that elevate the risk of breast cancer. And just to name a few, again, having a gene mutation. This doesn't happen often, but I have seen people who have had no family cancer history whatsoever and decide for recreational purposes to undergo genetic testing, and they find out they have BRCA, right? So this is not a perfect science. So there is a chance that people can still have a gene mutation, which elevates risk of breast and other cancers without having a family history. There's also, for people who have had a breast biopsy in the past that shows atypical hyperplasia, lobular carcinoma in situ. These are all what we call high-risk breast lesions. They are not precancers, but they basically mean that your lifetime risk of cancer, breast cancer is elevated as a result. These people meet criteria for more intensive screening with breast MRI, and they may be offered a lot of the risk-reducing options. People who have had a history of chest wall radiation, right? Some patients in their youth may have undergone chest wall radiation for Hodgkin's and things like that. Those people are also at an elevated risk for breast cancer. So my focus is generally on family history, but there are other risk factors that can make one eligible for supplemental screening, not just mammogram once a year, but again, breast MRI, which is a lot more sensitive.
Okay. There's a question, what type of physician or provider should you see a PCP and OB-GYN to discuss HRT?
Either are options, I would say. There are PCPs that this is an area of interest, and so they keep up to date and they're capable of prescribing. There's OB-GYNs that don't prescribe HRT very frequently or not well versed in it, and so I think finding somebody that you feel comfortable with, but I think both are options.
For those with autoimmune diseases that could increase the risk of heart disease, is there anything that can be done to lower that risk or at least determine it?
I mean, a lot of the main things to reduce cardiovascular risk would apply to people who have added risk for other conditions as well. The American Heart Association recommends 150 minutes of moderate aerobic exercise a week, as well as 75 minutes of strength training. So those are very important things. Not be a smoker. Know what your numbers are. If you do have high blood pressure, high cholesterol, it's important to get those treated. Treating those can have a good impact on your cardiovascular risk.
Thank you. So lastly, before we close today, can each of you talk about how philanthropy has impacted your work this far, and maybe what you think moving forward, the impact it can and hopefully will have? Maybe start down on the end with Versha.
Great. Philanthropy is so critical right now. I'll give you all a great personal example was the study that I am doing, the genetic risk assessment with mobile mammography, is partially funded through an institutional K through the NIH and partially funded through private funding from philanthropy. And given all of the delays and sort of hiccups in government funding right now, thankfully, our project has received private funds and has not skipped a beat. Our research team has continued moving forward, and we are still screening people, and we're identifying women who could be at high risk. It's really, really important that we provide this service to them and that we continue with this research. And it's been made possible historically through both funding mechanisms, but unfortunately in the climate in which we're living right now, we are highly dependent on philanthropy to get the answers to these really important scientific questions. So it is critical. it is so very important. I often tell people that we think of research as this sort of nebulous, far-off thing where people are sitting in a lab and, right, looking at molecules and things like that. What we need to recognize is that when we go to the doctor's office and something is wrong, the doctor prescribes us a medication or an intervention, and they're doing that because someone did research on this previously and came up with this answer. That's why they're doing it. So everything that doctors do is based on some prior research that was done. And so it is not a nebulous, far-off thing. It impacts all of us every single time we step into the doctor's office. So it is really important that that research continue, and particularly for women's health. We have to keep pushing things forward and advancing things. And we do that through research, and moving forward, philanthropy is going to play a huge role in that.
I'll echo what Versha said. Basically, some of the reason that this has been sort of a neglected topic for many years is in 2002, there was a headline after the Women's Health Initiative had to pause their study because they found an increased risk of breast cancer in women taking hormones, and there was a press release, and then the next day, everybody was like, oh, we can't prescribe hormones, they're dangerous. Fortunately, that study has continued, and because that study has continued, this is why we're getting better information about treating perimenopause and menopause. And the Women's Health Initiative continues to go on. You may have seen in headlines that the funding was briefly decided to be paused, and then it wasn't. And so if there's not philanthropy in these areas, then we're at risk for not advancing women's health and making sure we're taking care of half the population as best we can.
All right, really well said. My area of focus is peripartum cardiomyopathy, which is a form of heart failure that happens right at the end of pregnancy. And so I have been able to look through our patient records and our patients, and we're studying a new drug that could be helpful, but really through support, then we can do this type of research, we can do the statistical analyses, we can collaborate with other people at other institutions for a rare disease that's really important. In the future, I hope we can expand this and look at more types of heart disease that are specific to women. So through that support, we can really advance the field.
Thank you. Donor funding has helped our educational projects, like the course that I'm teaching to our medical students, and also our research projects. But it also has enhanced the patient experience. So patients going through a pregnancy loss have benefited from philanthropy through a music therapy program and to our pregnancy loss support group, so that they can have the resources they need to recover, grieve, from their pregnancy loss, and get support from other people in the community.
Thank you. Thanks to our panel, and I want to thank you all for a great discussion. I'd also like to thank the members of our audience who are joining us today. They're really your thoughtful questions, and we'll hope to continue those discussion. And clearly, this is a really important subject. And the power of research, I think you heard, to try to make lives better. I'd like to thank our panelists for joining us, sharing their valuable expertise. I'd like to thank you for what you do every day to care for women and people, and to make sure that we're getting better and that we're pushing not just for research, but advocacy and making sure that we're providing the right care at Michigan Medicine. And I know that these four amazing physicians do that 24/7. I'd like to extend our gratitude to our community of donors who've supported much of this work in many ways. I'd like to thank those who've supported our Women's Health Initiative Fund, which has helped support not only these researchers and faculty, but others across Michigan Medicine. And I want to thank our past and our current and hopefully our future supporters. It's very important that we continue to have this innovative research focused on women's health. You know, we're at a really pivotal time in research right now. honestly, day to day, I can't tell you how things are changing. We don't know whether our NIH studies that we thought were funded are going to continue. We don't know if we're going to lose a whole generation of physician scientists who are focused on women's health and other conditions that impact all of us every day. So again, I just want to thank you all for coming. I want to thank those online who signed up. We will be, this has been recorded, and we will send out a link so that you can share this with your friends. Please share it. We are about educating. We are about creating the future for tomorrow. We're about improving the lives and the health of women and people everywhere. So thank you, and I'd encourage you, these webinars, and well aware, to go to that website and see what's coming up. I also want to thank our great support team and our philanthropy team here at Michigan Medicine for helping us put this event together today. So enjoy the sunshine, have a great day, and go blue.